Good afternoon, everyone. Thank you so much for joining us today. We are pleased to welcome you to the APMEN Exchange webinar. We are discussing today moving steadily toward malaria elimination in times of COVID-19. And we will be reviewing experiences from the greater Mekong subregion. I'm Jocelyn Newcomb. I'm your moderator today. I'm pleased to welcome you all. I know we have participants still joining. Thank you so much for making time and for being with us today. I'm pleased to introduce the hosts of today's webinar, which include APMEN, APMEN, and the Regional Malaria CSO Platform. As many of you know, APMEN, the Asia Pacific Leaders Malaria Alliance, is a coalition of the Asia Pacific heads of government who have committed to eliminating malaria in the region by 2030. And APMEN seeks to accelerate malaria elimination and to address last mile challenges of ending this historical health issue. In addition, we are being co-hosted by APMEN, the Asia Pacific Malaria Elimination Network, a sustainable collaborative network for the delivery of technical malaria expertise. APMEN uses a brokering approach to connect national malaria control programs with relevant technical expertise. And APMEN comprises of NMPs across 21 countries in the region and 50 technical partner institutions. The Regional Malaria CSO Platform is a platform for civil society organizations working with communities at risk of malaria and other health issues in the region, including mobile and migrant populations, ethnic communities, forest goers, and internally displaced communities. Since its establishment, the platform has created a network of more than 50 community-based organizations, including national civil society and international nonprofit organizations working across the region. The APMEN Exchange is a series of webinars hosted by the APMEN Secretariat to support sharing of information and knowledge across the network of partners working in Asia Pacific. And we are so pleased to have you all with us today. We are going to introduce today's webinar firstly by describing the plan for our time together, and then we will introduce our wonderful panelists. We are going to, we have disabled the audio and video of all of our participants, but we encourage you to please add your comments and questions using the chat box. We hope that this will be a very interactive session today. So we encourage you to contribute by chat, and the team will be monitoring the chat, and we will be feeding your comments and questions into a discussion section that we have following the panelist remarks. Secondly, we wanted to explain the format for today. We have four very dignified and qualified expert speakers today. They will be answering questions, and we will be leading them through a discussion. We have decided purposely to minimize the use of slides during today's webinar, so please feel free to respond to the answers to the questions as we're having the discussion. You can also upvote a question by clicking a thumbs up if you want to reinforce a question or a comment that has been provided by another member. And we will, at the end of the panel, have space for discussion. We will also have a quick poll before our closing remarks. So that's the plan of action for today. If there are any questions about the plan, please put them in the chat for us, and we can respond before we begin the panel. We would like to briefly introduce our wonderful panelists. We are so grateful to have four panelists joining us today. Dr. Bullam from Simpe in Laos. We are very, very pleased to have you with us. Dr. Bullam, welcome, and thank you so much for joining us. Secondly, Professor Frank, joining us from Myanmar. Thank you so much, Frank. Thirdly, Ms. Nguyet from HPA in Vietnam. Thank you, Nguyet, for joining us. And fourth, Leven from Cambodia. He's representing the Malaria Consortium experience in Cambodia. So we have four panelists, and we have a series of questions. Each of them have graciously made time to join us today. And we thank you so much for your time and contributions. I'm going to turn it over to the panelists in a moment. But first, we want to briefly introduce the reason that we're here today, in addition to this wonderful discussion with the panelists, is to officially launch this wonderful case study, which has been jointly produced by APMEN and the CSO platform, Malaria Free Mekong. You can see the beautiful cover of this case study here on the screen. It's titled Moving Steadily Towards Malaria Elimination in the Times of COVID-19. And we are so grateful for the contributions from many national malaria programs and CSO partners across the 5 countries in the greater Mekong subregion, which have helped contributed to this case study that's being launched today. The summary of the case study in brief, the findings are quite in-depth, and I hope you will all read it and use it in your ongoing work. But we're very excited to launch this case study and to utilize this as an opportunity to highlight the wonderful work that's happening in the greater Mekong subregion to pursue elimination, and at the same time contribute to the pandemic response across the region. We know that the countries in the greater Mekong subregion reported a relatively low number of COVID cases in 2020, but as the surge starting from April 2021 and continuing at this time demonstrated, it has been critical to address challenges to elimination programming in this context. And there are some wonderful learnings from the good work that the National Malaria Control Programs in partnership with CSO and private sector partners have generated in these times. So we know that from the experience in the region, there are a few top line key takeaways that this case study aims to highlight. The first is the importance of political commitment and the leadership and in several cases whole of government support for integrated efforts to maintain elimination programming and integrate malaria programming in the context of COVID-19 are really remarkable, with national task forces being set up to review COVID-19 and malaria and make decisions in multiple countries. In some countries, including Cambodia, we've seen subnational level task forces set up to steer these integrated discussions and ensure that malaria programming stays on track despite the pandemic. So that is a key takeaway. A second key takeaway is the importance of community health workers, and we've seen in these times even more than ever the importance of strong community-based outreach networks, driving malaria elimination activities, and also contributing to the pandemic responses. And I believe that several of our panelists will share more with us about this key insight. Thirdly, all countries in the GMS have adapted the mode of operations with respect to their elimination programming to ensure continued elimination activities, even in spite of some interruptions and restrictions related to the pandemic. We've seen a really exciting use of new innovative digital approaches, replacing face-to-face trainings with more virtual digital or mobile approaches, including an increased use of social media. We've seen distribution strategies evolving from door to door to more distanced group distribution points, for example, and many other examples, some of which will be discussed during today's panel. Fourth, clearly there's a continued need for donor support for both malaria and the pandemic response in these countries. I believe that goes without saying, and I know that our panelists from 4 out of 5 countries in the GMS will demonstrate really Hi, everyone. Can you hear me? I'm so sorry. I lost connectivity.
Yes, Justin, we
Can you hear me
fine.
clearly?
Yes, absolutely.
Hi, everyone. Can you hear me now?
Yes, yes. We can hear you, Justin.
I'm so sorry. Can you all hear me?
Yes, we can hear you.
Thank you. I think our connection is not great, but we will proceed. Ritika, is your screen sharing on your side?
Yes, Jocelyn, it's sharing on my side.
Wonderful. Thank you. Now I can see it. Apologies. I was just reviewing some of the top line findings and key insights, which are described in the case study that we're launching today. And I believe I had described the first 4. So let me continue. Number 5, a key insight regarding the role of global, regional, and local partners working together. In addition to donors, we appreciate and we've seen the critical value add from technical and implementation partners who are supporting the national malaria programs and ensuring that malaria services continue to reach the most vulnerable populations, particularly mobile and migrant populations in remote areas, even and in spite of the pandemic. And we'll be hearing more about these contributions from all of our panelists. Sixth, we've seen some really interesting innovations in terms of the supply chain responsiveness. And as we've learned, with support from UNOPS, several countries in the region have been closely monitoring stockouts and have been adjusting to unprecedented challenges with new and flexible adaptations to ensure that essential malaria commodities remain available across the region. And we may be hearing more about that from some of our panelists as well. Number 7, strong surveillance systems are important to elimination in any times, but particularly in pandemic times. And as we've seen throughout the region during the pandemic, all 5 countries are investing in ramping up their surveillance systems to facilitate faster responses to outbreaks of both malaria and COVID. That continues to be essential. And last but not least, we've seen the private sector playing a critical role to both supporting elimination and the pandemic response, as we have seen several private sector companies and organizations across the region have stepped up their commitments to support governments in the COVID response and also maintain their contributions to elimination programming. So in light of the recent outbreaks across the greater Mekong subregion, it's clear that the impact of national malaria program and other high-level political leadership combined with support from civil society partners as well as the private sector has been essential in sustaining elimination programming and results, continued progress toward the goal of eliminating across the GMS and wider Asia Pacific by, if not before, 2030. And in addition, we have seen remarkable contributions to integrated malaria and pandemic programming. And we're very much looking forward to learning more about a few of the country-specific examples and learnings from our panelists. So I would now like to begin our panel, and I will invite Frank as our first speaker. Dr. Frank, welcome and thank you for joining us. And our first question for you is, please, can you describe how have the needs of communities at risk of malaria changed during the pandemic and in light of the current political situation? Over to you, Frank.
Right, so can you hear me?
Yes, we can. Thank you for checking.
Well, I think that the most important malaria needs in these remote communities are largely the same. The needs are the same. The question is, have their needs been fulfilled? And I like to separate that for COVID and for the very specific Myanmar political conflict situation. For COVID, the malaria needs did not change much. Remote communities were generally less affected by COVID. And the most important intervention that we have seen, and that you also just mentioned, is the presence of a community health worker. They do the malaria service in these remote communities. They provide the early diagnosis and treatment. And that service can continue as usual. That is the strength of community health worker. As long as the Department of Health and the NGOs keep supporting them and keep sending supplies to the community health workers, then there's no problem. And they usually have already the impregnated bed nets. Some investigations are more difficult to conduct, but they are, in my opinion, less essential. We have seen in so many communities that simply the presence of a community health worker can eliminate malaria in a community. And when we look at the ABER, the amount of tests done, which I think is a very good indicator of the services provided, then we don't see much change when we compare 2019 and 2020. So before COVID and after COVID was introduced, the diagnostic and treatment services were about the same. There was one big problem though, and that's the problem of referral. Some villages were locked down, some areas were locked down, and also people were afraid to go to the town because the town is often seen correctly as a large source of COVID. So people, we saw less referrals, and that's of course very serious, as these are the most severe patients. And it will be interesting to see what we could do about it. About the political conflict and the security situation in Myanmar, this is more complicated. Community health workers can usually continue their activities even in bad security situation. We saw that before in the southern Chin state in 2019, when there was quite intense fighting, but the malaria activities largely continued. That is, again, one of the strong points of these community health workers. They are in their community, the people are in the community, and they can provide the service as long as the Department of Health or the NGOs have given them enough supply and visit them when the fighting is low to replenish the supply. But after the political crisis in 2021, I saw a presentation of WHO, and they mentioned that 62% of the sites have not put in any reports, any malaria reports. Now, why is that? I know that most NGOs, they still give their reports to the database. And I think that it's largely the Department of Health supported ICMV, so community health workers, where we have no reports from. Why did they not report? I hope that communication was difficult, but that they are still doing their activities. But then again, have they been resupplied? And if they were resupplied, why do we then not have a report? Because if you supply, you can also get a report. So that is a big problem. I don't know what's going on in these communities. And we need to find that out because it's 62% of the sites. And I think maybe extra action is needed to address particularly the supply of the community health workers. Thank you.
Thank you so much, Dr. Frank. I think that you've highlighted several key points there. One, the importance of ensuring that community health workers, that the supplies, the critical supplies are maintained for them. And secondly, the reality that community health workers function not in isolation, but are part of a broader health system, a mixed health system in most countries. And thirdly, the importance of transparent information shared across all partners to enable us to jointly identify and solve key barriers. So thank you. We're going to come back to you in a moment. But first, we're going to turn to Dr. Bullam from Simpe in Laos. Dr. Bullam, welcome. And we're looking forward to hearing from you a little bit about the experience in Laos. We understand, Dr. Bullam, that Laos had very few COVID cases in 2020, but that like many countries in the region, you have seen a surge in 2021. And we're curious to learn more from you. Are you experiencing new challenges with respect to malaria elimination efforts in light of the recent outbreak? How have acceleration strategies that you are leading been revised in light of the pandemic? Over to you, Dr. Bullam. I think we need to unmute Dr. Bullam.
Thank you. Good afternoon.
Good afternoon. Go ahead. Thank you. The floor is yours, Dr. Bullam. Go ahead. Were you able to hear the question?
Good afternoon. Can you hear me?
We can hear you. There's a little bit of an echo, but we can hear you clearly, Dr. Bullam. Did you hear the question, or would you like me to reframe the question for you? Shall I restate the question? Were you able to hear it? Can you hear me clearly, Dr. Bullam? I can see you clearly, but I'm not sure that you can hear me. Can you hear me?
Can you hear me?
Yes, we can.
The two is internet have issue.
A little bit of technology issues. No worries. Yes, go ahead.
I'm sorry, we have problem about the connecting. Now available for you. Can you hear us?
Perfectly, and the echoes.
Thank you. Okay, I would like to answer your question now. From my experience, the new science to malaria elimination in light of the COVID region high COVID-19 case in Laos. After upticking of the outbreak COVID-19, the second wave of COVID-19 break out in April 2021. The government of Laos PDI was announcement to lock down the country, such as the close any cross-border checkpoint at national and local level, and also strictly secure movement of people from the area to another area. Also close small or big supermarket. That include also the investigation and screening people who at least and secure people who got infection and free of charge for accommodation and treatment of COVID-19. However, you know well, Laos country is still low middle income the country, so people are still like I would like to say many people still poor. So the accommodation need for people to live alive. So made the people mobile population move place to place. So made more spread the disease in the around the country. Also number of people mobile population from neighbor countries allow from neighbor countries to come to country back to country again and more. So make disease spread in the country. This one reason make the more very challenge for the government to control the COVID-19. However, for the malaria elimination that involved during the lockdown, we don't know really the number of the mobile population movement from the neighbor country, which are legal and also illegal, come back to my country. How much? We don't know exactly. We need calculate June. So we miss calculate for June. ILN also testing tests, drug, and also education tools, etc. for malaria control or malaria elimination. Second point, we have the test rate is decreased during the first lockdown, but more increase after programmatic update. And third point, we have the lack of the or not enough number of test kits in some targeted area due to strictly lockdown in that area. Human resource for the work for public health are limited to for malaria. They are also interested and for Zoom or interest only COVID-19 quarantine and control COVID under task force committee COVID-19 recommendation. Working by only meeting is not matched with the implementation and approach practice for malaria control and elimination. We have a more challenge, and also number of PPE which distribute to the on the country, like mesh, gel, glove, soap for hand washing, also face glove, glass, not enough for our staff or for the partner to work with us in the first of the lockdown. However, Simpe allow nominate, I have not nominate, have a monitoring the key programmatic update from the June until now. So we have 4 or 5 points to say about this. We have to update for training. Example, we have ICCM, surveillance and district health information version 2 training. We have ongoing, but still delay due to COVID. And but for the meeting, we have bottom-up meeting, planning meeting. We have malaria elimination committee work with us, and we have weekly meeting with the provincial. For the surveillance, we have outbreak response in the south. Also, case investigation and foresee and response in the elimination malaria area. And we have a weekly SMS reporting in the high burden village and health facility, and also entomology survey length. We have also PF elimination acceleration, because we conducted like a pilot project in Khammon province, middle part of Laos, but we complete our TDA2 Laos in that area. Also, the pyramids required for the IPT. We have also start up the plan for Southern Province approached by Global Fund. And also we try to update a PV radical curve, like a C6PD, loan arm, like a health center in Southern, we are complete. And health center in Northern and hospital, we are complete. And for the accommodity forecasting, we have also submit to the UNO and also approved by Global Fund. For the second, your question, how to accelerate strategy being revised in light of COVID-19? Actually, I do not want to say we have a revised acceleration strategy in light of COVID-19, because we just conducted a pilot project for the PF elimination acceleration strategy at the Bolapa district, Khammon province, that we expand to other south province in Laos for next year. But we complete, like I said to you, TDA to Laos, and also Primac required for IPT. in the pilot project. All of data from the pilot are still analyzed relate the real situation of the geography southern middle part of the country. Also relate with the COVID lockdown now. However, we are cannot complete like agenda at our setting due to lockdown of the province. Whatever, for the Public Health Emergency Operation Center, I would like to share with you also, POC is one of very important role of the task force community COVID-19, which function for reporting, prevention, and also sharing networking for information and control COVID in the that they are include the upper level of government and also provincial, central, district, and also community level. POC is one only COVID work, not only one 19, but relate some emerging infection disease and also NTD. They work like that. So for malaria, like a malaria of weekly management, weekly with the provincial and district and some partners to work with us. The meeting is similar like a EOC meeting, but not like strictly EOC. But we just look for a programmatic update in some province because due to occurring the lockdown, we have to know exactly the situation in there. But with some place they can access to the area. With some area they cannot access to work for our malaria. So the data malaria are also reported to POC weekly. However, anywhere, if we need to work in the field of the provincial or some district in somewhere in our country, we need to work like implementation for malaria activities. So we can discuss with the POC and also community COVID-19 to get a permission document and also approval by them. We can access to that. Thank you beforehand. Thank you for your attention. Have more questions, please. Thanks.
Thank you so much, Dr. Bullam. Several wonderful points there, and thank you so much for sharing your experience in Lao. I can see that there's a lot for all of us to learn from the wonderful approaches that Lao is using. I thank you for reminding us of the way that the mobility patterns have shifted, both domestically and cross-border in these times. I think that's a very important point. So thank you for highlighting that. And thank you so much for sharing this bottom-up approach that Lao has been using at subnational level to use surveillance data to inform targeted responses both to malaria and COVID-19 outbreaks. I also have heard clearly you're reinforcing a point that I think Dr. Frank made about the need to ensure that the supplies and the human resources are aligned with the localized needs. So thank you so much for highlighting several of those key points. We're going to come back to you with another question in a moment. Thank you, Dr. Bullam.
Thank you.
You're welcome. And now we'll turn to Ms. Nguyet from HPA Vietnam. Nguyet, thank you so much for joining us. Welcome. We're very much looking forward to learning more about the important work that HPA has been doing together with NIMPE in these times. And we're wondering if you can share with us a little bit about how HPA and NIMPE have collaborated to improve the response capacity to mitigate COVID-19 in Vietnam. Over to you, Nguyet.
Thank you, Jocelyn. Good afternoon and good morning, everyone. Regarding the question, how HPA support NMP and NIMPE in improving the response capacity to improve the COVID-19 impact on malaria program, I have to say that we couldn't do much But still, I want to share with you what we have done together with NIMBY. First, now, as you may know, HPA is a working partner of the project Improving Response Capacity to Mitigate COVID-19 Impact on TB, HIV, and especially Malaria program. So HPA has worked alongside with NIMBY to ensure the malaria prevention, diagnosis, and treatment services continue despite the COVID-19 pandemic in Vietnam. What we have done, actually this project has been approved since October 20. So up to now it's about 15 months. However, we only have 3 to 4 months to conduct the activity and the rest mainly for meeting and still waiting. So let me share with you what we have done in those 3 or 4 months. And we collaborate with NIMBY to develop the guideline for malaria control in the context of COVID-19 pandemic in Vietnam. And after the guideline completion, we together with NIMBY, we organized 3 offline training for nearly 200 staff of the Provincial Center for Disease and Control in 36 affected provinces. And then also we organized the online training course about those guidelines for nearly 500 health staff, the 7 CDC, also the district center, and also the communal health center and village health worker. Besides this, we provide sufficient PPE for all our working staff and frontline malaria health worker and volunteers. So that's what we have done in those 3 or 4 months during the period of 50 months. And we hope that in the year 22 and 23, we will be triggering to do more activity of this project. So besides this one, as you know that HPA is quite active in working in Vietnam nowadays, and we are working under RIDE 3E with the national component and regional component, and we commit with the project design to the donor here, the Global Fund, and we get approval in 7 provinces as per our timeline. So we already start working from middle of the year till now, and we achieve the proper result in malaria control and elimination. And what we can do else is that we bring to Vietnam about 118,000 antigen tests for COVID-19. And this we will hand over to NIMBY, and that will be provided to our 7 provinces and all our working health staff and also high-risk malaria population. And the aim of those provide the antigen test is to increase the awareness and understanding using of the antigen test for all the working health staff, and also we will conduct training for them, and then they will guide all the local health staff like the village health worker and the volunteer to use the test when they do both the malaria activity and also with COVID. So that's all. That's all. That's what we have done so far together with NIMBY to support NIMBY how to improve the capacity in responding to the malaria under the COVID context. Yeah. Not much, sorry.
Thank you so much, Nuya, and your humility is one of your many strengths. So I appreciate that. And I think that you're being a bit too humble, because the work that HPA has been doing with NIMBY is truly remarkable, especially given, as you highlight, the relatively short amount of time that you've had to program these innovations. And I'd just like to highlight how much we appreciate hearing and learning more about the work that you are doing to integrate rapid antigen testing and screening for COVID-19 into community level case management for malaria in 7 prioritized provinces. That is definitely an emerging good practice in the region, and we all look forward to learning more from HPA and NIMPE as that effort unfolds. Thank you, and we're going to come back to you in a few minutes, so stay with us, please, Nuyet. But now we're going to turn to Levin from Malaria Consortium in Cambodia. Levin, welcome. Thank you so much for joining us today. And we're wondering if Levin, you could kindly share with us a little bit of insight based on Malaria Consortium's experience in Cambodia regarding the changes that your organization and your community outreach teams have noticed at community level along the border areas in particular related to the pandemic and ongoing elimination outreach efforts. Levin, over to you.
Thank you very much, Jocelyn, for the introduction and for inviting Malaria Consortium for this webinar. Thanks. It's a very broad question, but I would like to summarize. As you correctly said, Jocelyn, we implement in malaria, or we offering quality malaria services in the most remote places, in the most remote areas along the international Cambodian border. So the border with Thailand, Laos, PDR, and Vietnam. And mostly we talk about population of forest goers, mobile migrant population, plantation workers, rangers, soldiers and their families all along the border, often living really far away, sometimes a day traveling to the nearby health center. And it gets more difficult during the rainy season. So looking at the situation, I think I could summarize in 3 main points. The first point is the changes that we noticed in the border crossing, in the people moving from one country to another country. And this has briefly been mentioned by Dr. Bullam, which I completely agree. Like if we compare with the border with Vietnam, there we can really see a clear, strict closure of movement of people. Talking with forest goers recently themselves, they really said no. Now it's just impossible to go to Vietnam, or people, a local population from Vietnam coming to Cambodia and our provinces. With Laos PDR is the same. In some areas, we really hear from our, because we work with mobile malaria workers, so we hear from our mobile malaria workers that there is no more exchange at all. They don't meet people at all anymore coming from Laos PDR, except then in Virakchai National Forest. And then in Thailand, again, if you go to the other side of the country, it's a completely different story, because there we saw like a high influx of Khmer and of Cambodian migrants coming back from Thailand, because everything was closed there because of the pandemic. So there was quite a fear that some people had to stay along the border in the forest, that this would mean that there would be an increase of malaria cases, which luckily we did not see. But COVID-19 put a lot of pressure on the health centers along those border with Thailand. So that was specifically this year, because as already correctly said, 2020 in Cambodia, COVID was more a problem for the capital, for the big city, and for the foreigners coming into Cambodia, while this year, 2021, we could really see the spread of the COVID virus everywhere in the whole country, even in those remote areas where we were working. So you could see that the people were more afraid, definitely more afraid of each other, let's say. They were more afraid to go to the health centers. The health centers were also extremely busy. But the strong thing, the good thing is that the village malaria workers and the mobile malaria workers from the Malaria Consortium project along the border, that these people, they're all from the community. They're really chosen from the community. They know each other. And we already provided before COVID masks and alcohol and hand gel because they were going outreach. So we wanted to have, for us it was like hygienic, basic hygienic material. So we just increased a lot during the COVID, also to be able to give to people coming for testing, so they could wear a mask, they feel more safe. So this really saved us, I think, saved the big progress that has been done in Cambodia in those areas. So we did not see a decrease at all of people tested, people at risk tested by our mobile malaria workers, even an increase month after month, and also the village malaria workers, they did not see any decrease. Village malaria workers are working in more do passive case detection usually and are more based in the village. While in the health centers, yes, there was some decrease of malaria testing. So that was the second point. And then maybe the last point is, but this really needs to be confirmed by proper data analysis. The schools were closed since 2020, and we could see in some areas, in some border areas, not in all the provinces, an increase of more children and more ladies, female, who were malaria positive. And this trend in some areas continued now in 21. Again, I say we need to do proper analysis, deeper analysis, to see if this is related to the closure of the schools, because the number of the balance or the proportion of female and male that our mobile malaria workers tested did not change compared to previous years. So we could see really a kind of increase that might be related to schools that are closed or were closed, and the whole family going to the plantation in the forest or along the forest fringes for their activities and stay there more. While before, children were often staying in the village with the grandparents or family members when the parents were working in the plantation. I could go on more, but I will not do it, Jocelyn. I think these 3 points for us were like the most important points that we have seen, and with the most, like the main thing to say is that thanks to this proximity actually of the mobile malaria workers and also the village malaria workers in the country, that there was not really a disruption in testing, or meetings were still conducted, although one. So there were a lot of restrictions, but everything could go on, and the National Malaria Program clearly instructed a lot to keep on working on malaria, not let it go, by distribution of commodities in time, pushing to have the meetings ongoing despite all restrictions. That should be it. Thanks.
Wonderful. Thank you, Lieven. You've shared several really interesting experiences and insights with all of us. And I think you've in your last comment, you've just emphasized the importance of that high-level political commitment to sustaining elimination activities throughout the pandemic, which the NMPs and other government stakeholders really deserve so much credit and acknowledgement for. So thank you for highlighting that. And I think it's really important that you're emphasizing, how community health workers, and in this case, in Cambodia's case, the mobile malaria workers and the village malaria workers who come from the communities themselves, who live with the communities, who are forest goers themselves, are so critical to sustaining effective malaria elimination programming. I think that's really important to emphasize, and really wonderful to hear from Malaria Consortium's work. You and your teams are testing, as I understand it, 6,000, you're conducting 6,000 malaria tests a month. And as you mentioned, that has been sustained, if not increased throughout the pandemic, which again is testament and thanks to these incredibly committed VMWs and MMWs within the communities. So thank you for sharing that. And really interesting data that you and your team are beginning to unpack with respect to possible gender and age implications of COVID-19 on elimination and malaria risk in particular. So thank you for sharing that. And I think we have another question for you, but first we're going to turn back to Dr. Bullam. Dr. Bullam, are you still with us? We would like to invite you to say a little bit more about the emergency operation centers. Dr. Bullam, can you hear us? Are you still with us? Wow. Thank you.
Sorry.
That's okay. That's okay. I think that you were very efficient in your first responses, and I believe that you said you shared quite a lot of information with us, and some of our participants are asking questions through the chat and other channels to try and understand more about how these emergency operation centers for public health are operating in Laos. Maybe you could say a little bit more about how they work and how the COVID-19 and malaria and other health issues are being addressed in an integrated fashion through these EOCs in Laos. Over to you, Dr. Bullam.
Yes, thank you, Shah. I would like to say POC or Public Health Emergency Operation Center in our country is very important role for the control COVID-19. Not just controlling COVID-19 now, maybe all the disease, not even only emergency infection disease, that include neglected disease also. I would like to say now the task force committee use POC is one very important role to work for them, because POC have to reporting, preventing, sharing information network, and also work with the community. I would like to say like that. But whatever, they not just work for some disease, some emergency. For malaria, they also work with us. Like dealing with, if we need to go work or implementation activities, malaria in the area. So we have to ask the POC to discuss the POC work with us and got approval from that document. And also committee task force agreement with us to work with them. Exactly, simply, we have like a meeting management malaria weekly, like a similar POC do, but we call like a just management malaria meeting. But we have a reporting some part of them, like a malaria case, report to the POC, because POC have to respond with us. POC work with and also respond for malaria outbreak in southern part of our country also. We have to report for them, we work with them. Yes, thank you very much.
Thank you so much, Dr. Bullam. It's very helpful to learn a little bit more about how the EOCs are working and how the coordination and the communication across programs and functions and levels is happening in Laos. I think that is something that, again, that other countries in the region can learn from. And as we all know, as the caseloads fall, integrated management of multiple infectious diseases and particularly in COVID times becomes more and more important. So thank you for sharing this innovative work in Laos with all of us. Thank you. I'd like to invite Dr. Frank to rejoin us now. And Frank, we're hoping that you can share with us some of the innovations that Medical Action Myanmar has been using to maintain progress towards elimination in Myanmar in COVID times. Looking forward to hearing more about some of these really exciting and interesting adaptations that you and your team are using. Over.
Right, thank you. I'm not sure if they are very innovative, and I'm also not sure how interesting they are, but anyhow, I will do my best. I think the first problem we had to overcome is that people, including our staff, were very afraid at the start of COVID. Some people, they thought that they would or are going to die, and that is among the staff, while they are generally very young. So what we, in order to make sure that we could maintain the activities, we had to advocate and discuss with the staff to continue the health activities, to reduce the panic. NGO staff, I think, at least with MEM, they are generally young and they have a very low COVID risk. During the peak in this year, actually, we had over half of our staff got COVID, and there was one person who needed oxygen, and he recovered well. And that was actually quite a strong indicator. So I'm talking about 500 staff, and only one needed oxygen. So we try to convince them that sure, there is a danger, but the danger is relatively small. And then we provide them, of course, with PPE and other preventive measures. And then in our offices, in all our field offices, we had a supply of oxygen concentrators and medicines, so that in case there was a complication, that we could deal with it immediately. About security, because we are in Myanmar, we talk about COVID and about security. Security risk is clearly there, is high. It's very difficult to deal with. We had a number of staff who got arrested and then later released, not for any clear reasons. I mean, there was obviously, they had nothing to do with any insurgency. But on the other hand, also there, we have to reduce the panic a little bit. We are not a target, and normally, and we will not be in the middle of this fight. But it is an important issue. Advocacy to staff, but we also need advocacy to authorities, to the ethnic health organizations. They were very much trying to lock down their communities, and we tried to discuss with them. We had a number of meetings with them to discuss that it's very important to not have a complete lockdown, and at least have a continuous supply of the community health workers, because they are the key, as I mentioned before. That's in the current state. In the Chin state, when there was fighting, we discussed with the military and with the Arakan army. We discussed with both sides to allow us to transport medicines and to do our activities and visit these villages, and that was successful. Then less successful was to cover the migrant population. As you might have heard, because of the security situation, there is an increase of migrant population. And we have trained some of them to provide diagnosis and treatment, but usually that's actually not possible, because it's very high risk, because the powers that be, they link them with the civil war. So the moment we supply them, we would support the civil war, and that is a very clear threat. We have been stopped a number of times. We were not allowed to move medicines because it was suspected that we would provide the opposition with these medicines. So advocacy to continue the services, they were sometimes successful and sometimes not. Particularly in 2021 was very, very difficult. And then we did continue to focus on the hotspots, on the high transmission areas, and we did do large-scale active case detection in these remote villages in the southern Chin state and in Cayenne state, and that is again after discussion with the authorities. I think that's it. Yeah, and if we saw not in the hotspots but in new transmission areas, there were a number, Kachin particularly. Yeah, we tried to intervene with large screening also and treatment. That's about it, I think. Thank you.
Professor Choi, to add additional information. Thanks.
Thank you, Dr. Frank. Lots of wisdom there. And firstly, let me just acknowledge your important point that elimination and COVID-19 response effectiveness doesn't always need to be innovative. The basics are also important, and you're absolutely right to share with us and emphasize the importance of ensuring that our teams on the ground feel safe. And thank you for sharing both the medical and the security, as well as the advocacy to ensure that that our teams are informed and feel reassured that the work that they are doing is important and essential, and that we are providing them as much as possible with a safe infrastructure and context to work. I think that the other key point from the Myanmar experience that you're emphasizing is that public health interventions must be sustained in any political context, and the work that Medical Action Myanmar is doing to ensure that these communities in very remote areas, similar to some of the other stories that we've heard on the panel today, that their needs are being met, and the remarkable work that Medical Action Myanmar is doing with support from local authorities, following your advocacy with them to ensure that these communities are continuing to receive support and essential health commodities and services. Very remarkable work that you and your team are doing. Thank you, and thank you for sharing.
If I may, I'd like to stress on one point, and that is the advocacy to the staff, and I think that is for all CSOs very important. I think that there is a kind of a tendency to say there's COVID, so let's stop all work and let's stay at home. But I think it is. I mean, you could say that for many diseases. You could say that for TB or for. I mean, every year there are 20,000 deaths of TB in Myanmar, and nobody has ever worried too much about that. But with COVID, it's suddenly. And also among young people, they think they cannot work anymore. And I think there is an important task of all NGOs to discuss that with them and really encourage them to continue. Thank you.
Thank you so much, Frank. We would like to invite Ms. Nuyet to rejoin us. Please, Nuyet, I hope you're still with us. We understand that HPA has done some really important work to modify the work of the malaria outreach teams in Vietnam to adapt in light of COVID-19, and we're looking forward to hearing more from you about that work. Over to you, Nuyet.
Yeah, thank you, Jocelyn, for a very nice question. Because MOT is a strength of HPA in Vietnam. So let's say at this moment from from 21 to 23, HPA will work in 7 provinces in Vietnam, and we may expanding in case in the future. But at this moment, we are covering 37 provinces, 12 districts, and 39 communes. So we set up 39 MOTs in those provinces. And our MOT will deliver malaria-related service in more than 300 villages and covering more than 300,000 populations. And one MOT team will include one malaria volunteer and one village health worker. And their main task is to provide the malaria-related service, including malaria testing, RDT and microscopy, conducting IEC, BCC, and case follow-up, treatment, and support. And normally one MOT will do about 20 days per month for active outreach activities and mobilize anytime as per request by CSC or by community and even other CHSO like SCDI or VPHA in case they need our support. And how our MOT adapt under the COVID-19, we together with the MOT team, of course, we understand the situation and we together build up a plan for our MOT. Let's say this in short term, let's say it is like a strategy plan for the MOT. But the thing they have to commit to do is to sustain essential malaria service at clients' home for even under the social distancing context or the new normal context. And next, they have to strictly follow 5K message from the MOH. They will be fully equipped by PPE provided by HPA, plus antigen tests for COVID-19. And especially we contact the local authority to give them priority that all our MOT must be vaccinated. And the most interesting thing is that during the last year, when the CSC, the commune health center staff are mobilized for the COVID-19 control force, and our MOT almost like do the job, all the job relating to malaria intervention. So they can not really replace the CSC staff, but like on behalf of CSC, they do the testing, diagnosis, they provide the treatment and follow up. And we also have a very good monitoring system applied for our team MOT, that is the digital by MNE. We set up the digital data reporting, and in order to do so, we organize like a weekly meeting every 2 weeks and monthly meeting with all the MOT. We train them for MNE, and also we provide them any other trainings that to improve their capacity building. And we try to create the, let's say like the most interesting working environment for the MOT. So by the result for the last 4 months, they detect 20 cases among 25 cases from the whole community where we are working. And we reach nearly more than 80% of the case in the community. So I think that is from our MOT.
Thank you, Nuyet. What an interesting story, and I know that that there's some more information that's been shared in the chat for any of our participants today who are less familiar with the MOT model. And I believe there is also some information about this exciting work that you have been leading together with Nimpe in the case study. So there's more for our participants and others to learn about through the case study. Thank you so much for sharing that. And again, I think it's coming back to the critical importance of bringing services, products, services, information as close to communities as possible, and this bottom-up approach together with the critical importance of flexibility in these times. So thank you for sharing that experience with all of us.
You're welcome.
We're going to turn back to, yeah, good, thank you. We're going to turn back to Levin and ask him one final question. Levin, thank you for staying with us, and we're looking forward to learning more about your thoughts and the thoughts from others on the team at Malaria Consortium in terms of your experience in these times and your advice regarding, for all of us working in elimination, in terms of how CSOs and national malaria programs can coordinate better to serve the needs of communities and to ensure that our programming is community-based. Looking forward to your thoughts on these important issues. Over to you.
Thanks, Jocelyn. I don't know, you call me expert or expertise, but let's see. But I think you gave already a part of the answer, or at least the answer that we see, or that I have in mind, based on the observations here and on the work done with and within communities along the Cambodian border, and working with locally recruited mobile malaria workers. I think looking for resources, looking for strengths in and within the community is really important. I mean, from one side, you have the resources in the community, and from the other side, you could say, so what I wanted to say is, like, you have the resources in the community. Let's use them. We saw it during the COVID-19, especially this year, as I mentioned before, that thanks to the fact that we invested, and with we, I not only mean Malaria Consortium, but also mean the national program, all the other partners, the fact that we invested, that we brought malaria services so close to the population, and based on their experience how to do best, is really strong, and could also be an answer for any other need that would occur within communities. So it's really this model of how in the future could we do this more integrated approach. Just sharing our experience, we are going to these very remote areas with these, and we target this remote population, this hard to reach population. But for now, we are working in a very vertical way. We are there for malaria, but our teams, our staff, and also our mobile malaria workers, they see sometimes other issues, other problems. There might be dengue, there might be possibility to do deworming, to very basic healthcare that could be integrated and bring closer to the communities. And luckily, this is also the plan in Cambodia on the longer term, because Cambodia is in the elimination phase now. So on the longer term, the village malaria workers who do more integrated approach. So I think that is really powerful. In our case, we support these community activities with community dialogue, where we really bring together people from the community, start to look from their health problems, their health-seeking behavior, and look what are their resources. So it's really this community-based oriented approach. I think that would be very helpful. Always making the link with the national program and with the health centers. This is also what we do now. In any activity, health centers are integrated. In these activities, we invite them, because often we see, especially now with COVID, people are a bit afraid sometimes to go, or there is less trust because they might be infected if they go there. But to bring people to the communities from the health center, to make the link with our mobile malaria workers is a very strong, very strong fact. Another thing that I just want to say is the investment as well. and the support to the communities and to the staff, to the mobile malaria workers working there. I'm really happy that Frank mentioned it's not always a good solution to stay home because of COVID. This is also what our team preferred not to do. We only went in quarantine when some of our colleagues became positive, just to be a bit careful. But we always try to continue to do the activities, and even had to convince in one province the provincial authorities that what we do, our activities, are one-one activities, and that we could do it in a safe way, respecting all the safety and security rules to prevent from COVID, while other NGOs in that area temporarily suspended all their activities. So I fully agree with that. Like, adapt yourself, adapt together with your community, and see what is possible. It's maybe a very broad answer, Jocelyn, but I think that the key is there, and this more integrated community work, let's say. I hope that gives an answer to your question.
Very much so. Thank you, Lieven, for
Thanks.
emphasizing the importance of ensuring that that we are building our activities and our programs with the needs of communities in mind, and that means that, especially as cases drop, and we're working with more and more remote populations, that we bring an integrated lens, and that we're listening first and responding secondly, and that means providing more than malaria care, ideally. So thank you for highlighting that, and also for emphasizing this flexibility with safety approach in these times for all of the teams that are working so hard to maintain elimination activities. We have a question for all panelists. Anyone who would like to respond, we're going to transition now to a brief Q&A section. Thank you to all participants who have shared questions in the chat. And we would like to highlight a question related to vector control interventions in these times. And the question for all panelists is, given the population movements, which have in some cases intensified and shifted, as several of our panelists have highlighted in these times, as well as COVID-19 and political situations, how has the coverage of vector control changed in these times in your country? And are there any new needs or gaps that you are seeing? Any innovations you'd like to share with us that you're using to address those gaps? Are there any of our panelists who would like to speak a little bit about how COVID-19 has impacted the vector control programming in the countries where you're working?
I could do if you want, Jocelyn.
Go ahead, Lieven. Thank you.
There were some restrictions of movements, of course, like in every country, especially beginning of this year, there were some restrictions. So then there were some problems of how to get, let's say, the LNRN from the capital to the provinces, and from the provinces to the more remote areas. But there was a good stock, there was provision, there was distribution. This is mainly for Malaria Consortium. If I look at the country or countrywide, the mass distribution continued. Definitely there will be other people who are more specialized to discuss about this, but I would like to share what I heard from Cambodia, that the mass distribution is ongoing. Only the way of distribution has completely has changed and has been adapted. So instead of working in villages with village chiefs and distribution, gathering households or gathering families, the budget has been reviewed to really distribute more, let's say, from house to house. So not collect people, not bring them together, but still continue to distribute, but a bit more time intensive probably, and with a bit higher budgets. But this is as far as observed in Cambodia what has been the answer to this COVID pandemic from that point. Thanks. I hope that's an answer, at least for Cambodia. Yeah.
Thank you so much for sharing that. Clearly, the distancing requirements are having a significant impact on vector control and other aspects of elimination programming. And it's good to hear about some of the adaptations that are taking place in Cambodia and probably other countries. We have one question for Dr. Bullam. Dr. Bullam, are you still with us? Hoping that you can kindly rejoin us.
Yes.
Oh, wonderful. So Dr. Bullam, the question is regarding the work that SINPE has done to revise the standard operating procedures and the guidelines for elimination programming in light of COVID-19. And our participants are wondering if you can share a little bit of information about how the SOPs have been revised in Laos in COVID times. What was the process that you used to revise those? And are there any significant updates or changes that you would like to highlight? Over to you.
Exactly, we don't say about SOP, but belong of our working, we just update belong of our strategy, malaria elimination. We have to monitor any activity just we done belong of the malaria elimination strategy. And also we just add more only PF accelerate strategy in there. Yes, thank you.
Wonderful. Thank you so much for sharing those refinements with us. Thank you all to our participants for staying with us. We have a brief poll that we're hoping you will all participate in. And I believe that you're going to see it coming up. So as you see it come up on your screen, please respond to the poll, and we'll wait for all responses and update you regarding the next steps. Thank you so much for contributing. Thank you for all of you who are completing the poll. I think you can all see the results coming up. Please, if you haven't yet completed the poll, we'd be grateful to all of our participants if you could kindly complete it.
I cannot vote inside, thanks.
And I would now like to turn the program over to Amita for some closing reflections and remarks. Amita, the floor is yours.
Thanks so much, Jocelyn. It's such a fantastic discussion this afternoon. I think Professor Frank's comments really about innovation gave me a lot of food for thought. I think, when you think about innovation, there's such a lot of pressure for it to be bright and shiny and unique. But just listening to the discussion, I think, the fact that innovation can really be many small ways of just the way we change the way we do things, right? And I think the pandemic and our experiences in the greater Mekong region have particularly shown us that it's these small little ways in which we adapt the way we do business as usual, which are innovative as well. The second piece that really struck me from today's discussion is just the humility on the panel, whether it's Dr. Bullam, who spoke so unassumingly about the fact that they actually launched and implemented an accelerated elimination strategy in the midst of a pandemic. And of course, Nguyet, who downplayed the incredible amount of work that they've been doing. It actually reinforced the reasons why we wanted to do this case study. We wanted this case study to document the best practices and learnings from within the region, and really highlight the small little big ways in which the programs, the communities, and civil society have been able to come together and meet the challenges imposed by the pandemic. So I'm hoping that this case study will not just be a documentation, but is also something that will help us as a community internalize what we need to do when faced with change. And I think, from the experiences from the 5 countries, from civil society, we have a sort of a blueprint that will help us build our implementation muscle really to be able to, address future challenges. To use a cliche, I think change is the only constant. And while I sincerely hope that we'll be able to put the pandemic behind us, I'm almost certain that there will continue to be challenges that we face, whether it's in terms of, political challenges, supply chain disruptions. Business as usual is never going to be a constant. And so experiences like this, the documentation that we do through the case study will really help us identify key elements of that implementation muscle that we need to build. As you mentioned, Joss, at the beginning, I think there's some specific themes that we were able to highlight from the GMS, particularly around leadership commitment, sustained financial commitment, the way programs and civil society organizations were able to integrate and adapt to meet the challenges of the pandemic. We find that these themes are actually reflected across the region more broadly as well, beyond the GMS. And so APMEN is hosting a high-level leaders dialogue on the 13th of December to really shine a spotlight on some of the ways in which programs across the region were able to adapt and continue service delivery and really take stock of what is it that we need to do between now and to reach the 2030 elimination goal. So this is a meeting of senior officials. The registration to the meeting is in the chat box, and I'm really hoping that all of you will be able to join us for a half day of discussions and really keep this conversation going, which is much needed. So thank you very much.
Thank you so much, Amita, for ending us on a high point, as you always do. Very wise reflections. And I would like to thank all of our panelists who spoke without slides, which is not easy, and spoke so compellingly. And thank you for your time, all of you. I believe we have a video that we're going to share before we close. Yes. Is the video coming up on the screen, team, or are we sharing it in the chat? Ah, there it is. Thank you all. And it looks like we'll be together again in a few weeks following that video. Thank you so much for joining us. Stay safe, everyone. Thank you.
Thank you very much.
Bye-bye.
Bye.
Thank you.
Bye.